General principles: surgery is a potent activator of the hypothalamic pituitary axis, and patients with adrenal insufficiency may lack the ability to respond appropriately to surgical stress. Patients receiving corticosteroids as anti-inflammatory therapy may rarely develop postoperative adrenal insufficiency. The dose and duration of exogenous corticosteroids required to produce clinically significant tertiary adrenal insufficiency is highly variable, but general principles can be outlined. 100 for daily therapy with 5 mg or less of prednisone or its equivalent alternate day corticosteroid therapy, and any dose given for less than 3 weeks should not result in clinically significant adrenal suppression. Patients receiving greater than 20 mg/d prednisone or equivalent for greater than 3 weeks and patients who are clinically Cushingoid in appearance can be expected to have significant suppression of adrenal responsiveness. The function of the hypothalamic pituitary axis cannot be readily predicted in patients receiving doses of prednisone 5 to 20 mg for greater than 3 weeks. Diagnosis: concentropin stimulation test may also be performed to determine adrenal responsiveness, measuring a single cortisol level at 60 minutes after 250 grams of concentropin. This can be done any time of day and baseline cortisol is not needed. Levels greater than 18 g/dl at 60 minutes generally suggest an intact hypothalamic pituitary axis. Treatment: if there is concern for secondary adrenal insufficiency, it is reasonable to simply continue prior steroid dosing perioperatively. 106 It may be prudent to switch to an IV formulation to ensure it is not withheld while the patient is NPO. For patients with primary adrenal insufficiency, a stress stratification scheme has been developed, based on expert opinion,